Welcome to the YF Nutrition Science Center Virtual Learning Series. This activity is equipped with interactive features from Slido. We will be using the Q&A and poll features later. For now, we would like everyone to click Join Event so you may enjoy the rest of the session. For those using laptops and iPads, you may use the tab on the right side of your screen for the different interactive segments like Q&A and polling. In sending questions, you may put your name on the box beside the send button. For those using mobile phones, we suggest the use of portrait or vertical view. Scroll down and find the Join Event button and click. You will see the Q&A and polling features below this video. You may send your questions anonymously. If you wish to include your name, click on the profile button on the upper right-hand corner of the chat and type in your name. If and when accessing these features, please note that the live broadcast streaming might stop for some mobile phone devices. This might cause you to miss some portions of the program. If your video stops and you want to go back to the lecture, just scroll up and click the live broadcast button. This will take you back or forward you to the real time of the lecture. Join us today as we enrich our knowledge and expertise in nurturing, nourishing, and raising the next generation of Filipinos. Welcome to the YF Nutrition Science Center Virtual Learning Series. Welcome to the YF Nutrition Science Center Virtual Learning Series. This episode is held in partnership with the Philippine Obstetrical and Gynecological Society in pursuit of the latest in scientific nutrition information. WNSC continues to provide healthcare professionals access to cutting-edge, science-based knowledge on maternal, infant, and pediatric nutrition. Learning never stops at the YF Nutrition Science Center.
In this rapidly evolving world, the only way for us to survive and thrive is to be adaptable to change, to keep up with the pace of progress, and to embrace new advancements and technologies. This has propelled YF Nutrition with its firm commitment to disseminate scientific nutrition information to establish the YF Nutrition Science Center as a credible nutrition science platform that supports healthcare professionals in nurturing healthier generations of Filipinos. The YF Nutrition Science Center has been taking strides to develop relevant and accessible learning platforms that provide cutting-edge nutrition science information from major health and training institutions to renowned local and global nutrition experts. The YF Nutrition Science Center equips healthcare professionals with the latest and relevant scientific information, supporting and empowering their professional growth through convergence, empowerment, connectivity, and access. Don't just keep pace with the changing world. Take the lead in nurturing healthier tomorrows with the Wyeth Nutrition Science Center.
Good afternoon, my dear doctors and colleagues. Welcome to the Wyeth Nutrition Science Center Virtual Learning Series. The current situation has tested us individually and collectively as medical professionals. And as we continue to serve children and their families in these difficult times, we still find ways to continue our learning and education. While we are unfortunately not able to be physically together to learn because of our current situation, technology has allowed us to explore various alternative methods that will continue to enhance our overall learning experience. And so today, I am excited to welcome you to an exciting digital learning opportunity, which is the Wyeth Nutrition Science Center Virtual Learning Series. Once a month, until November, we will have our experts in the field of pediatrics, nutrition science and research share the latest and relevant scientific information to enrich and empower us to provide even better patient care. This is the commitment of the Wyeth Nutrition Science Center, dear doctors. We are here to partner with you in your learning and professional development so that together we may nourish and nurture the next generation of Filipinos.
Here are my humble hands, Lord, chosen to receive your creation. Here is my open mind.
Good afternoon. I'm Dr. Cristia Padolina and welcome to the Wyeth Nutrition Science Center's Virtual Learning Series. On behalf of the Philippine Obstetrical and Gynecological Society, welcome everyone. Today, I am so glad that even if it is just through the computer, through our cell phone, we still stay in touch with each other. Especially now during the pandemic, obstetricians should really know the facts regarding maternal and pediatric nutrition in as much as patients are demanding for this information real time. This is why, for this particular engagement, I am particularly happy and proud of our partnership with Wyeth Nutrition Science Center, in as much as the virtual learning provides us time to reach out and have the right information at the right time so that we are ensured that our healthcare professionals continues to have access on it. For today's episode, I am truly proud that we have one of our very own lecturing. This obstetrician gynecologist will lecture on the dangers of diabetes mellitus during pregnancy and how we could better cope up with this condition. Mother and baby are truly at risk with complications, and truly with this, I would like to invite everyone for happy learning, happy teaching, so that we are able to appreciate the totality of our knowledge. This lecture will also earn you CPD units. Please stay tuned until the end of the program so that you'll be able to find out how to claim your CPD units. And so for now, let me now introduce to you our lecturer. Today's lecturer has completed his OBGYN training program at the Quezon City General Hospital and has received his fellowship training in maternal and fetal medicine and ultrasound OBGYN at the MCU FDT Hospital. Currently, he is also an associate professor Professor 1 in 2 institutions, mainly that of the Department of Obstetrics and Gynecology at Our Lady of Fatima University, and also Department of Biochemistry and Obstetrics and Gynecology at the same institution where he had his fellowship at MCU, FDT, MF, Hospital College of Medicine. Right now, he also serves as the head of the perinatology section at the Department of OBGYN at the Jose Fabella Memorial Medical Center, and also the chair of the Department of Obstetrics and Gynecology at the Valiches District Hospital. He is likewise a immediate past president, I should say, of the Philippine Society of the Maternal and Fetal Medicine, guest board of examiner of both the Philippine Society of Maternal and Fetal Medicine and also of the Philippine Society of Ultrasound in Obstetrics and Gynecology. Currently, he is a member of the POGS Committee on Hospital Accreditation. My dear colleagues in OB, to discuss the topic on double trouble in diabetes mellitus during pregnancy, let us all welcome Dr. Richard Georges.
Diabetes mellitus. Silent and easy to miss. Defined as glucose intolerance of variable degrees, first recognized during pregnancy. A disease dreaded worldwide from 173 countries. GDM estimates up to 28% globally. Overall mean prevalence of GDM in Eastern and Southeastern Asia is 10.07%. Southeast Asia has the highest prevalence of hyperglycemia in pregnancy, where a quarter of the pregnancies are affected. In the Philippines, pregnant women are at a higher risk because of ethnicity. From 2012 to 2017, there was a total of 9,881 diagnosed with GDM. More than half of women with GDM ultimately develop overt diabetes in the ensuing 20 years. There is mounting evidence for long-range complications like obesity, diabetes in the offspring, likelihood of fetal death, maternal and fetal birth trauma. This afternoon, we'll tackle double trouble.
Good afternoon. First, I would like to thank Quiet Nutrition for inviting me to this afternoon to talk about diabetes mellitus in pregnancy. So first, let us define what is diabetes mellitus in pregnancy or gestational diabetes mellitus. So GDM is a serious pregnancy complication in which women without previously diagnosed diabetes develop chronic or spontaneous hyperglycemia during gestation. In most cases, this hyperglycemia is the result of impaired glucose tolerance due to pancreatic beta cell dysfunction on a background of a chronic insulin resistance. Now, these are the different forms and types of risk factors for the development of gestational diabetes mellitus. This would include, first, patients who are overweight or obese or with BMI of greater than 25 or even 30, westernized diet and micronutrient deficiencies, advanced maternal age, and a family history of insulin resistance and or diabetes mellitus itself. Okay, so during healthy pregnancy, the mother's body undergoes a series of physiological changes in order to support the demand of the growing fetus or even the embryo on the earlier part of pregnancy. This would include adaptation or physiological changes to the cardiovascular, renal, hematologic, respiratory, and metabolic system. Now, one important metabolic adaptation is in insulin sensitivity. Over the course of gestation, insulin sensitivity shifts depending on the requirements during pregnancy. Okay, so during early pregnancy or gestation, insulin sensitivity increases, promoting the uptake of glucose into the adipose stores in preparation for the energy demand of the developing embryo and fetus. However, as pregnancy progresses, there is a surge on the secretion and production of placental hormones, which includes the following. We have the estrogen, the progesterone, leptin, cortisol, human placental lactogen, and human growth hormones. So this altogether promote a state of insulin resistance. As a result, the blood glucose is slightly elevated, and this glucose is readily transported across the placenta to fuel the growth of the fetus. Now, this mild state of insulin resistance also promotes endogenous glucose production and the breakdown of fat store, resulting in further increase on the blood glucose level as well as the free fatty acid concentration in the system. Okay, so let us discuss the pathophysiology of diabetes mellitus in pregnancy. Now, you could see in this screen the response or the physiological adaptation, particularly the metabolic adaptation in pregnancy, and how is pregnancy itself responds to increasing blood glucose level. Now, the beta cells, blood glucose, and insulin sensitivity during healthy or normal pregnancy, and of course, the development of GDM will be shown later on the succeeding slide. During normal pregnancy or healthy pregnancy, the pancreatic beta cells, so this is the pancreatic beta cells. So this will undergo hypertrophy and hyperplasia. Hypertrophy and hyperplasia of the pancreatic beta cells in order to meet the demand of pregnancy. The blood glucose level, okay, or the serum blood glucose usually rises, okay, and insulin sensitivity is somewhat fall. Now, following pregnancy or postpartum period, the pancreatic beta cells, the blood glucose and insulin sensitivity returns to normal. Okay? So, what is quite important as a physiological response during pregnancy is that because of the peripheral insulin sensitivity decreases and there is a slight increase on the glucose level on the maternal serum, there is a compensatory hyperplasia and hypertrophy of the pancreatic beta cells. Now, for those who are destined to develop gestational diabetes mellitus, okay, so what happened is that in GDM, the beta pancreatic cells, okay, so the beta pancreatic cells fails to compensate for the demand of pregnancy. And when combined with reduced insulin sensitivity or peripheral insulin sensitivity, this results to increased blood glucose level or hyperglycemia. Now, following pregnancy, the pancreatic beta cells and the blood glucose level and insulin sensitivity may return to normal, or it may be remain impaired on a pathway towards the development of gestational diabetes mellitus in the future pregnancy or the development of type 2 diabetes mellitus. So here are the different organ systems which is affected by beta cell dysfunction and hyperglycemia. So we have the adipose tissue, we have the liver, the gastrointestinal tract, we have also here the brain, the muscles, and the placenta. And what is quite important, of course, as the effect of hyperglycemia, there is an increase on the fetal growth or somatic growth of this fetus, and this fetus is prone to develop what is known as fetal macrosomia. Now let us discuss the different screening methods for the diabetes or GDM in pregnancy. First, we have here the 75 grams oral glucose tolerance test, which is proposed by the American Diabetes Association and the International Association of Diabetes and Pregnancy Study Group. The cutoff for the fasting blood sugar is 92 milligrams per deciliter, and the 2 hours for the OGTT is greater than 153 milligrams per deciliter. Anything which is below 92 and 153 is normal. Second, the World Health Organization or the WHO proposal is that the fasting blood sugar should be at least 125 milligrams per deciliter. The first hour is 180 milligrams per deciliter, and the second hour is 140 milligrams per deciliter. Anything which is below 125, 180, and 140 are considered to be normal. Now, number 3, we have the 75 grams oral glucose tolerance test, which is being proposed by the American College of Obstetrics and Gynecology. The value is 92 milligrams per deciliter for fasting, and for 2 hours, OGTT, we have 140 milligrams per deciliter. Anything which is below 92 and 140 is considered to be normal. Now, the Philippine Obstetrical and Gynecological Society in 2018 recommends the following. Universal screening for all Filipino pregnant patients on the first prenatal contact or visit using fasting blood sugar. Okay? So the fasting blood sugar, which is the cutoff is 92 milligrams per deciliter. If it is less than 92, then it is normal. If it is between 92 to 126, that is gestational diabetes mellitus. And if the value is greater than 126, this patient might be an overt type of diabetes mellitus. Now, among high-risk patients, okay, so please take note of this. Now, all patients should be assessed properly if patient is high risk, if the initial fasting blood sugar is normal, then you have to follow this immediately with 2 hours, 75 grams oral glucose tolerance test. Now, the value for the 1 hour is less than 180 milligrams per deciliter. And for 2 hours, we have 150 milligrams per deciliter. If the value of the 2 hours is more than 200 milligrams per deciliter, then we are dealing with cases of an overt type of diabetes mellitus. Okay? So please take note of this. On the initial visit, initial contact, during antenatal care, prenatal care, please try to assess if your patient is high risk or low risk for the development of glucose intolerance or hyperglycemia or GDM. Okay, so because we want to further assess and further evaluate our patient, that's why it is not enough that we have to request for the fasting, but rather we have to immediately request for the oral glucose tolerance test on this patient. Now, for low-risk pregnant patients, okay, if the initial blood fasting glucose is normal, so it is less than 92 milligrams per deciliter, then we have to perform and reserve the 2 hours, 75 grams oral glucose tolerance test between 24 to 28 weeks age of gestation. Which means if the initial fasting blood sugar is done on the first trimester of pregnancy during the first prenatal contact or prenatal visit, and it turns out to be normal and your patient is considered low risk, then you have to reserve and postpone the 75 grams oral glucose tolerance test between 24 to 28 weeks age of gestation. Again, please take note of the value. For fasting, we have 92 milligrams per deciliter. We have a value of 180 for first hour, and then we have 153 milligrams on the second hour. Okay, so after the 24 to 28 weeks age of gestation, we could again screen our patients and retest it at 32 weeks age of gestation or earlier if there are clinical symptoms and signs of maternal and fetal hyperglycemia. So this is an important factor and an important things that we have to bear in mind, especially as a physician, to take note if there will be maternal and fetal hyperglycemia that you could see on your patient. And then probably if there is significant or there will be signs of hyperglycemia, then you have to retested at any age of gestation after 24 to 28 or preferably at 32 weeks for 75 grams oral glucose tolerance test.
So, thank you, Dr. Jinky, for the first part only of your lecture. And of course, before proceeding to the second part, let's have some breather. Let's have some poll questions so that we will be able to be abreast with what has just been lectured, and at the same time, we could feel the audience. Okay? So, Dr. Georges?
Good afternoon. And good afternoon to all obstetricians who are watching as far as the northern part of the Philippines and the southern part of the Philippines. We have friends texting me from Cagayan de Oro City. So let us check knowledge with our fellow obstetricians. We have here 4 sets of questions. So I would like you to press the button of the corresponding answers that you usually perform or do in your clinical practice. So may we have the first question? Uh, the first question is, how many of your patients are diagnosed with hyperglycemia in pregnancy or gestational diabetes mellitus, especially in your private practice? So we are asking our fellow obstetrician, Dr. Padulina, what is the percentage of patients diagnosed with GDM? Because we know for a fact that the incidence and prevalence is quite high for Filipino gravid patients. Is it letter
Agree.
A? Yes, ma'am. Is it letter A, less than 10%? Letter B, 10 to 20%? Letter C, 20 to 30%? And letter D, greater than 30%. Okay? So,
Okay, so Jinky, let me just remind our colleagues that if they are using a mobile phone, you will find the poll tab at the bottom, okay, of the lecture. That is where they should be able to press it. Okay.
okay. So, in your practice, Doktora, how many percent or how many patients? Nagpa-practice ka pa ba?
Of course. Oo. Kailangan mag-practice kasi kung hindi, hindi makakalimutan. Plus, I think this is innate to all obstetrician. The main reason why we went into OBGYN is the uplifting effect of course, delivering babies, of being touching base with our patients. Okay, and thank you, Dr. Jinky, for emphasizing the importance of the incidence. Oh, this is the results. Let me read it out, Dr. Jinky.
Yes,
The
ma'am.
way, the top choice is letter B, 10 to 20%. And that's for a whopping 45%, followed by less than 10%. So can we get your reactions? Did our colleagues get it right? Because this
Okay.
is glued to the burden of the disease.
So, if the majority of our obstetricians and clinicians would have a 10 to 20% cases of hyperglycemia or GDM diagnosed in their clinic, which means one or two out of 10 patients usually develop GDM or hyperglycemia in pregnancy. This is quite true in private practices, but we have to take consideration, Doctora, that we have a lot of cases in government institutions, cases that are being diagnosed and being referred to the high risk section of the hospital or institution. Almost 30 or 40% of high risk pregnant patients are usually diagnosed with
Outpatient, yes.
with hyperglycemia or GDM.
Okay, so let's go to the second question, Dr. Jinky.
Okay, so the second question has something to do with the lecture that was given, our first part. What is or when do you screen patients for gestational diabetes mellitus? Okay, so when is it letter A on the first prenatal visit, preferably on the first trimester of pregnancy? Letter B, is it at 24 to 28 weeks, age of gestation, for low risk pregnant patient? Remember my discussion regarding high risk and low risk patients. Letter C, at 32 weeks age of gestation, or roughly around third trimester of pregnancy. Or letter D, at any age of gestation once maternal and fetal hyperglycemia is quite evident and diagnosed.
Okay, so while our colleagues are answering, let me congratulate first the subspecialty of PSMFM for coming up with that guidelines, because this is what we really need. We need to standardize our care for our patients, and that is the one that is quite important, regardless of whether it's a private institution, public health, or government hospital. So Thank you. Congratulations to PSM-FM because you are a very dynamic society. Thank you.
Thank you, Doctora.
Okay, so the answers are coming in, Jinky.
Yes.
And number one answer is on the first prenatal visit, preferably on the first trimester. Okay, and this is followed closely at 24 to 28 weeks age of gestation. What can you say with that?
Well, it depends upon of what age of gestation you will see your patient in your clinic. Sometimes you miss the first trimester and you just, the patient is already on the second trimester nearing 24 to 28. So might as well proceed in doing the 75 grams oral glucose tolerance test on that particular age of gestation. But ideally, okay, for the first prenatal visit, preferably on a first trimester pregnant patients, we request for the screening for diabetes mellitus.
Okay.
I will not tell what type of screening is that, because the next question has something to do with the type of screening they usually request. Okay.
Okay,
So may
so can we have the third poll questions? Everyone's excited about it already.
Yes. Okay. So, based on my lecture, and based on your practice as well, what screening method you usually request, no, for the diagnosis of hyperglycemia in pregnancy or gestational diabetes mellitus? Okay, ano bang rine-request natin? Is it the availability, or is it the cost? Kaya tayo nagre-request ng mga screening method. Okay? So letter A, we have risk assessment for gestational diabetes mellitus at the first prenatal visit. Second, or letter B, we have fasting blood sugar or FBS. Madalas nabanggit yan kanina. And then letter C, we have 50 grams oral glucose challenge test or OGCT, followed by 100 grams oral glucose tolerance test. Okay, medyo kapanahunan ko pa yan, no? Nung mga rine-request yan. And then for letter D, we have 75 grams oral glucose tolerance test. Okay? So, Doktora, ikaw, anong practice mo? What do you request? What do you...
Alam mo,
oh,
Jinky, dito medyo nalulungkot ako eh. Okay? Time of pandemic, okay, we need to shorten the interaction, of course. Secondly, mas nalulungkot ako dahil sa government hospital because of the limited resources. And on a public health perspective, iba kasi. We do not want the request to be all the same. Dapat nag-a-adjust din on what is the expert's opinion. So definitely, the perspective should differ. Hindi po pwede yung kapanahunan pa namin at kapanahunan mo. Okay? It should adjust to the latest guidelines. Okay?
Yes, ma'am.
So, tingnan natin kung abreast at nakikinig ang ating audience. Oh, number one, Jinky, it's a fasting blood sugar for 50%, followed very closely by 75 grams OGTT.
Okay.
Tama ba?
Screening, as far as screening for hyperglycemia in pregnancy or GDM, we often request for the 75 grams oral glucose tolerance test, no? But part of the 75 grams oral glucose tolerance test is the fasting blood sugar. Kaya siguro meron tayong mga obstetricians na ang kanilang screening method is 75 grams OGTT. But as far as strict compliance for screening for GDM or hyperglycemia in pregnancy is concerned, then we usually screen our patient using fasting blood sugar, or FBS.
Okay. Thank you.
So
let's go to poll question
yes.
number 4.
Now for this last question, this will be discussed on the second part of my lecture, and I just want to have an idea on how our obstetricians, no, in their practice, perform or implement an initial treatment, no, for hyperglycemia in pregnancy or GDM. Okay, so ano yung mga modalities or how do they initially treat this patient? No, the ones they are diagnosed with hyperglycemia or GDM. Letter A, do they immediately refer this to the diabetologist or endocrinologist and start insulin therapy? Letter B, we have medical nutritional therapy and exercise. Letter C, we have oral hypoglycemic agents. Okay? And letter D, we have food supplementation and multivitamins or even micronutrients. Okay? Because in some studies, doctora, there is a link, there is a correlation with when it comes to the micronutrient deficiency and the development of a certain metabolic syndrome or metabolic diseases during pregnancy. And one of this is GDM.
Let me take it on the perspective of the patient. We really need to teach them because on their perspective, pagka injectable, either mas mabisa or mas malala yung sakit nila. So, I'm sure magtatanong sila sa atin. Okay?
Yes.
So, yeah. So, let's take a look at the results. And let's see. So, basic. Letter B, the answer at 94% of the time, medical, nutritional, therapy, and exercise. And a very small portion for insulin at 4%. Okay. So,
Okay.
Dr. Richard?
Yes,
Correct?
Doctora. Oh, so nice to see that most of our practicing obstetricians uh, perform or assess the medical nutritional therapy as the first line of treatment modalities for our cases of GM or hyperglycemia in pregnancy. And I hope that all obstetricians, baka nakalimutan na doktora yung pag-compute ng caloric requirements. Minsan inaasa na lang natin sa mga residents or even to our fellows. But it is very basic that all practicing obstetricians should know how to compute for the caloric requirements which is needed, especially if there will be a glucose intolerance or there is already development of GDM or hyperglycemia in pregnancy.
Okay, so our colleagues should not forget the basics before going into the highfalutin management. At any rate, I will give the virtual platform again to Dr. Jinky Georges so that he will be able to discuss the management part on his second part of his lecture. Again,
Thank you.
Dr. Georges.
Now, what are the different forms and types of complications of diabetes in pregnancy? We are going to discuss both the maternal as well as the fetal complications of this disease. It was already been mentioned earlier in my discussion that there are certain hormones during pregnancy which is believed to be diabetogenic. These placental-derived hormones are the following. We have the human placental lactogen, we have the progesterone and estrogen. Because of this will of course cause decreased the tissue sensitivity, which is one of the effects of insulin. Now, if there is decreased tissue sensitivity, there will be sustained hyperglycemia. Okay? So what happens if there is sustained hyperglycemia? Hyperglycemia-induced metabolites disturbances in which there will be an increase on the free oxygen radicals. And this, in turn, would, of course, stimulate the production of certain vasoconstrictors as well as platelet aggregators in the form of thromboxane A2. Now, because of the proliferations of vasoconstricting agents as well as platelet aggregators, there is development of endothelial lining destruction and further narrowing of that blood vessels or vessel diameter. This would, of course, take effect on the macrovascular compartment in which patients is highly prone to develop myocardial infarction and even stroke. For the microvascular involvement, we have hypoperfusion and hypoxia. This will lead to resistance to certain infection and even um, preterm deliveries. Now, what are the significant complications that might be seen in our patients for cases of uncontrolled blood glucose level? We have nephropathy, retinopathy, neuropathy, and even the development of hypertension. Again, going back to the placental-derived hormones, okay, so this would, of course, cause a decrease on the tissue sensitivity to the effect of insulin. And because of this, there will be cellular and tissue hypoglycemia. Remember that the glucose could not enter the cells. That's why there is a significant tissue and cellular hypoglycemia as well as hypoxia at the background of an increased glucose in the serum of our patient. This will in turn secrete ketone bodies from the glucose-lacking tissue, and this would promote osmotic diuresis. Now, what happens is that there is metabolic acidosis and profound vascular volume depletion, and there will be loss of electrolytes, and this will further, of course, promote tissue hypoglycemia. Most of these patients would present with multiple organ failure, coma, and death. No, they usually present with diabetic ketoacidosis. So based on this algorithm or the possible development of complications, it is quite very important that diabetes should be properly diagnosed early in pregnancy and should be addressed accordingly. Now let us discuss what are the possible fetal complications. Again, we have here the placental-derived hormones, the human placental lactogen. We have the progesterone and estrogen. So the same pathophysiology, there is a decrease in tissue sensitivity because of the effect of insulin, persistent hyperglycemia, and there is the development of fetal hyperglycemia. Now, because of this, the same mechanism that is shown for the maternal complications, we have an increased free oxygen radicals, vasoconstrictors are present, and there is also platelet aggregators. This will entail endothelial lining destructions and narrowing of vessels, decreased uteroplacental blood flow, and we have seen cases of fetal hypoxia in the form of intrauterine growth restriction and even intrauterine fetal demise. We could also see some sort of fetal anomalies and evidences of pregnancy losses. Now, with persistent increase on the blood glucose level on the fetal compartment, we have fetal hyperglycemia. This fetal hyperglycemia or increased glucose on the fetal compartment promotes fetal diuresis and high concentration of glucose in the amniotic fluid. This would further increase the amount of amniotic fluid, and eventually you would end up having polyhydramnions. Polyhydramnions would, of course, overdistend the uterus, which is quite obvious that patients would have preterm labor and even preterm deliveries as a consequences of polyhydramnions. Next, we have fetal hyperinsulinemia. There is an increase on the glucose and fat deposition of on the fetal soft tissue, particularly on the trunk of these fetuses. And what is quite obvious, if there is too much deposition of fats, so this fetus would end up having fetal macrosomia. Now, fetal hyperglycemia related with the inhibition of oxygen and glucose delivery to the tissue. So what happens is that, again, there will be secretion of ketone bodies, and there is lactic acid is being produced from hypoxic and hypoglycemic tissue. Okay, so remember we have the glycolysis, aerobic and anaerobic form of glycolysis. The anaerobic form, we have the production of lactic acid. Fetal acidemia with acid mediated tissue damage to the different organs will of course promote embryopathies. Okay, so this would be the detrimental uh, complications, okay, of fetal acidemia, the development of a certain congenital abnormality, and sometimes unexplained intrauterine fetal demise. Okay, so we have discussed both the maternal as well as the fetal complications of diabetes mellitus. Let us now discuss and go to the medical nutritional management of diabetes in pregnancy. It is quite an important aspect of antenatal care and prenatal care that all pregnant patients on their first prenatal visit, preferably on the first trimester of pregnancy, is to compute, okay, the body mass index of our patient. Now, based on the body mass index or the BMI computed, we could project the weight gain, okay, the recommended weight gain for the entire duration of pregnancy. Example, if you have a patient whose BMI is 18.5 to 24.9, then the entire weight gain for the entire duration of pregnancy should be at least 11.5 to 16 kilograms. Okay, this also goes for those who are overweight, in which the BMI is 25.0 to 29.9, and for cases of obese, in which the BMI is greater than 30. Okay, so the total kilogram weight gain for the entire duration of pregnancy for obese patients should be less than 7 kilograms. Okay, now it is quite an important aspect that every residents or even consultants or practicing obstetricians should know how to compute for the caloric requirements. Okay, so the moment that we diagnose our patients having gestational diabetes mellitus, the first thing that we have to engage our patient with is for the medical nutritional therapy. And this is how we compute for the caloric requirements. There should be a balanced caloric distribution in terms of the different macro molecules. So we have here carbohydrates, which represents 55 to 70%, proteins 10 to 15%, and for fats, we have only 20 to 30%. Among the three macromolecules, the protein has the least percentage. Then we have to add an energy, okay, for the second and third trimester of pregnancy. And this is in the form of milk formulas, okay? We add at least 300 kilocalorie per day of energy, especially on the second and third trimester. Now, treatment for gestational diabetes mellitus includes the following. So, women with GDM should be advised to see a dietitian for an individual diabetic meal plan. And then we have to choose carbohydrates of low glycemic index. Okay, so you should be aware that there are certain carbohydrates with high glycemic index, which means the moment that you eat this one, the absorption is quite abrupt, and there is an abrupt increase on the glucose level in your serum. So you have to choose food with low glycemic index. Then we have to advise them to restrict caloric intake of at least less than 25 kilocalorie per kilogram per day. And what is also an important aspect in the management of GDM is not only engaging our patient for a medical nutritional therapy, but also we have to advise them to take moderate exercise. Okay? of at least greater than 30 minutes per day, especially for those with BMI of 27 and above. Okay, so after medical nutritional therapy and exercise, at least 2 weeks, then we have to reevaluate, okay, and advise our patient to monitor their blood sugar level, especially during fasting and 2 hours postprandial. For the fasting, no, the blood glucose level by in whole blood and in plasma should be less than 95 milligrams per deciliter, and for plasma, that would be less than 105 milligrams per deciliter. So you have to be very careful in terms of interpreting the value, and this value should be based on the type of blood glucose samples that you get from your patient. Again, we have whole blood and plasma. And the 2 hours postprandial value for whole blood, we have less than 120 milligrams per deciliter. And for plasma, we have less than 100 milligrams per deciliter. Okay, so consider hypoglycemic therapy for cases in which blood glucose level are not controlled by medical nutritional therapy or physical activity. So we also request for a serial ultrasound examinations, no, to our patient. And sometimes ultrasound results would give us or suggest us an incipient fetal macrosomia in which the abdominal circumference is more than the 70th percentile for age of gestation. Okay? Sometimes we have values of abdominal circumference, no, which is already out of order or out of range. Okay, so because of the very enlarged abdominal circumference or the transverse view of the fetal abdomen, when we measure the abdominal circumference, wala nang value na lumalabas. Masyado na kasing malaki yung kanyang abdominal circumference. Okay, so we have to take consideration of the different forms and types of hypoglycemic therapy that we want our patient to start with. Okay, so we have insulin, and we have the different forms and types of insulin analogs. We have the aspart and the lispro. Now, I have here the different forms and types of insulin, which is commonly prescribed by our diabetologists or even endocrinologists to our pregnant patients with uncontrolled blood glucose level by diet and exercise. So we usually start, with this insulin. Okay, so these are the different forms and types of insulin available in the market. The onset of action, the peak of action in hours, and of course we have the duration of action. Okay, so it is quite important for us to take note of this bioavailability of insulin in the system now of our pregnant patients. Now, aside from insulin, okay, we have to advise them with certain lifestyle modification. Okay, now one good thing about insulin is that it does not cross the placenta. That is why it is favored as the first line or form of medical treatment, for our GDM patients. While metformin and glyburide both cross the placenta and should not be used as the first line agent, as long-term safety data on the oral hypoglycemia or glycemic are insufficient. Metformin should be discontinued once pregnancy has been confirmed among women taking it previously for polycystic ovaries and for ovulatory induction. Okay, so again, what I would like to emphasize is that if the medical nutritional therapy and exercise fails, then we have to start with insulin with our patient. Now, after the delivery of the product of conception, we have to reevaluate again our patient. Okay, so very important that we have to advise them to come back after 4 to 12 weeks postpartum. And what we request is fasting blood sugar, or we request for the 75 grams oral glucose tolerance test. Okay, so what would be the expected value for us to further do interpretation or assess the hyperglycemic state of our patient? First, if the fasting, no, blood glucose is greater than 125, so this is for the postpartum period, okay? Milligrams per deciliter, or the 2 hours glucose is greater than 199 milligrams per deciliter, then patient is considered to be having diabetes mellitus. Okay, and we have to refer this for further management and, of course, medical treatment. Now, if the value is less than 100 milligrams per deciliter, or the 2 hour glucose is less than 140 milligrams per deciliter, then our patient has GDM, and our patient is already in normal state, okay, during the postpartum period. So we have to further assess the glycemic status at least 1 to 3 years, no, and then we have to advise for certain weight loss and engage more in physical activities. No, we have to do counseling for this patient. And the third, if the fasting blood sugar falls between 100 to 125 milligrams per deciliter, or the 2 hours glucose falls between 140 to 199 milligrams per deciliter, then a patient can be labeled as impaired fasting glucose or unimpaired glucose tolerance, or even both. Okay? So consider referral for management, referral to a diabetologist, advice for weight loss and physical activity, consider metformin. If combined or impaired fasting blood glucose and impaired glucose tolerance, no, is present for your patient. And then again, medical nutritional therapy should continue, and yearly assessment of the glycemic status of our patient should be properly advised and evaluated. Okay, so the treatment and the assessment for GDM does not end upon delivery of the product of conception. We have to follow up our patient 4 to 12 weeks, no, postpartum. Now, these are the recommendations, no, as far as GDM is concerned, and it is based on a consistent scientific evidence, which is level A. Now, women in whom diabetes or gestational diabetes mellitus is diagnosed should receive nutrition and exercise counseling. And when this fails to adequately control glucose level, medication should be used for maternal and fetal benefits. Now, when pharmacologic treatment of GDM is indicated, insulin is considered the preferred treatment for diabetes in pregnancy. All pregnant women should be screened for GDM with a laboratory-based screening test using blood glucose level. I believe that all laboratories, they are capable of screening our patient for fasting for 75 grams oral glucose tolerance test. Glyburide treatment should not be recommended as the first choice of pharmacologic treatment because in most studies, it does not yield equivalent outcome to insulin. And healthcare providers such as doctors should counsel women, no, of the limitation in safety data when prescribing oral agents to women diagnosed with gestational diabetes mellitus. I think this would be my last slide. Thank you so much for your very kind attention.
Thank you, Dr. Richard. Truly, that was a very enlightening, insightful presentation. And if I would gauge it to from the questions that our viewers are putting in, truly they are very engaged. So before we could go into the actual Q&A portion, let me now remind you as to the procedures in sending your questions. Please use the Q&A tab on your screen. You may send your question anonymously if you prefer it that way. If you wish to include your name, however, please click on the profile button and type in your name. If and when accessing these features, please note that the live broadcast streaming might stop for one reason or the other in your mobile devices. This might cause you to miss some portions of the program. If your video stops and you would want to be back on the lecture, just scroll up and click the live broadcast button. This will surely get you back or forward you to the real time as we are doing the lecture. Reminder also, the 20 healthcare providers who are most engaged in asking questions, garners likes or upvotes, will receive tokens from WNSC. So, let me now start off with our Q&A by calling our expert, Dr. Jinky Richard Georges, in order for us to start our formal Q&A. So,
Ma'am,
yes,
parang gusto kong magtanong.
ikaw muna o ako? Ako na.
Kasi
Seniority.
may mga special na gifts from Wyatt Nutrition.
Okay. Pagka mataas ang likes, no? Okay,
Yes.
so in your practice, Jinky, what is your preferred treatment intervention method?
The first line, of course, is the medical nutritional therapy, and I do advise my patient to have an exercise, at least walking within their subdivisions, or if the park is already open, no, at least 30 minutes to 1 hour of walking. And I always usually compute, no, for the caloric requirements for my patients who were initially diagnosed with GDM or hyperglycemia in pregnancy. And the distribution of the caloric requirements is already been mentioned. With regards to the macromolecules, we have 50 to 55% of carbohydrates, 10 to 15% for proteins, and 20 to 30% for fats. And please don't forget the extra 300 kilocalorie of energy per day. And this can be achieved by giving at least 2 glasses of milk formulas, no, for our pregnant patients, because they need energy. Sabi nga, energy, especially on the second and third trimester of pregnancy.
Okay, thank you, Dr. Jinky. Yung mga hindi nakatira sa subdivision, yung mga government na OB, dapat naglalakad din. Okay, so let me take a look at our slide though, so that we will take on the next question. So this is an interesting, Jinky. What is
Yes,
the physiology of a small baby from a diabetic mothers, wherein we expect them to be quite big and macrosomic? How come what we have are IUGRs?
Yes, this question is from Dr. Donna. So thank you for asking that. And it was already flashed on my lecture in the screen of fetal complications, that because of the narrowing of these blood vessels brought about by the proliferations of certain vasoconstrictors and platelet aggregators. Now we have thromboxane A2. So this narrowing of blood vessels decreases, no, the possibility of transferring oxygens as well as nutrients to the developing embryo and fetus. Actually, if I'm going to answer this in just one word, it is vasculopathy. Okay? So the reason for small babies for diabetic mother is primarily because of vasculopathy, which is quite common for cases of overt type of diabetes mellitus.
Okay, thank you, Dr. Richard. Can we now have the second question? Thank you, Donna, by the way, for answering that question. Okay, so the second question reads, when do you start antenatal surveillance for patients with GDM who are diet controlled? I think you should answer that in two ways, one during pandemic and one non-pandemic times.
uh, Dr. Aurora Tahan, okay, thank you for that question. Now, if you would look on the ECO guidelines in terms of when to start the antenatal surveillance for cases of hyperglycemia in pregnancy or gestational diabetes mellitus, especially if the blood glucose is controlled, we start at 40 weeks age of gestation. You will be surprised. 40 weeks, no? Is the start of the antenatal no surveillance. It's not 37, 38, 39, no? And we often request for the basic no antenatal surveillance, which is the biophysical profile or the biophysical scoring. This would include, of course, the non-stress test. Okay? Kasi kung minsan, modified mamang pinare-request nila. The amniotic fluid and the NST. But for these cases of GDM, which is properly controlled glucose, no, we usually request for the biophysical profile or the biophysical scoring, no, as a whole.
Okay, so let me address or let me take the last question, Jinky. But let me assure our audience that all the questions that you have posted will be answered and it will be posted in the Wyeth Nutrition Science Center website. Kaya lang talagang kapos kami sa oras eh. Blockbuster si Jinky. So let me read the last question, please. When is the best time to give calcium and until when?
Okay, so calcium, one of the micronutrients, no, which is believed to be beneficial during pregnancy. This is quite an important micronutrient in terms of decreasing the chances of having gestational hypertension and preterm labor. If I ask my residents, no, or sometimes my fellows regarding what is the benefit of calcium, ang sinasabi nila, it promotes stronger teeth and bones. Yan, di ba? Kasi calcium. But there is a very nice study, a research study, no, which is done in the Middle East, in which they get the samples of the serum calcium of these women who are considered to have a decrease, okay, or insufficient calcium concentration in the serum, okay. So these women were being given calcium. They found out, no, these pregnant patients, no, usually would have a decrease in the possibility or chances of having a preterm labor, and what is quite important is the development, no, decreased development of gestational hypertension. You could start at any time in pregnancy giving calcium, and you could extend that even after delivery or during postpartum. The recommendation is 1 to 1.5 grams per day.
Okay. Jinky, at this point in time, let me ask you to share a few words for our audience. And thank you for engaging us in this double trouble.
Okay. First, I would like to thank again Wyatt and, of course, the president of the Philippine Obstetrical and Gynecological Society, Dr. Cristia Santiago Padolina, no, for being here, no, supporting me. Well, anyway, in times of pandemic, the screening as well as the treatment for hyperglycemia in pregnancy or gestational diabetes mellitus does not change. Okay, I think the greatest impact of pandemic for cases of GDM is that this patient should be properly advised, no, when is the right time for them to have virtual consultation and when is the right time for them to have a face-to-face consultation. Because we know for a fact that patients or babies, no, from diabetic mothers could easily have certain complications, especially intrauterine fetal demise. Mas madaling mamamatay o kaya may mga mataas ang chances na mag-IUFT. That's why I would like to advise, no, our clinicians, no, to properly monitor and properly educate, no, this our patients in terms of the most cost-effective form of antenatal surveillance, which is fetal movement count, and see your patient as much as possible and request for this antenatal surveillance if deemed necessary. Okay, so please try to monitor and please try to evaluate patients, no, especially on the third trimester of pregnancy, because we have cases of which there is some sort of bad outcomes, no, especially on the third trimester for patients who are diagnosed with certain medical conditions.
Okay, thank you very much, Dr. Jinky Richard Georges. That was indeed very insightful. Ang galing, idol, ikaw na.
Thank
Okay,
you,
so
ma'am.
yeah, thank you everyone also who participated in today's open forum. We hope that today's lecture has enhanced your knowledge and of course will give you better insights on how to better take care of our patients. At this point, let us now conduct our post-evaluation survey. This will help us make the next installment of the Wyeth Nutrition Science Center Virtual Learning Series even better. This time around, please use the poll tab found on your screen. And a series of questions will be made. Please answer them right through. So question number 1, how would you rate the relevance of the lecture Double Trouble in Diabetes mellitus during pregnancy in your practice for being the highest? Poll question number 2, how would you rate the knowledge and expertise of our speaker? Again, 4 as the highest. Poll question number 3, how would you rate the lecture format of the Q&A sessions in between presentation? Again, 4 being the highest. And poll question number 4, how would you rate this WNSC Virtual Learning Series overall, with 4 being the highest? Please do not forget, after giving all your answer, to click the send button so that you could cast your vote and make sure that your polling answers are counted. Okay. And let me now navigate to the next part. And this one, what topics would you want to discuss in the future? Okay, and while you're keying in your answers, let me whet your appetite and tell you that the convention is coming in October 10 to 14. Our Vice President, Dr. BJ Cuenca, surely has cooked up a lot of things in our first virtual hybrid convention. Okay, and again, let us now go into the 6th poll question. Do you have any suggestions or comments for us to improve our future activities? Okay, continuing on with our hybrid convention, please, this is something that you will look forward to. Okay, we have an awesome social program. We do not want you to get a webinar overload during our annual convention. So please look forward to the social program that you and I will be joining. And last, what are your key takeaways from the lecture? So again, as a reminder to our colleagues, the convention, especially the annual business meeting on day 3, is a commitment that we provide and we need to attend as part of our obligation of being a good member of the POGS. This is also time that we are able to do our lectures. Okay, so with that, thank you very much for participating in our post-evaluation survey. Your feedback indeed is very important to us. And let's stay tuned for the next series of the WNSC Virtual Series, that we will ensure that our partners would make it very relevant to all of us. So thank you for listening. Please stay tuned so that you are able to receive your CPD units. Please expect an email from the WNSC for the CPD units. And this wraps up the lecture. Thank you very much. Good evening.